Hello and welcome to the review of the final day. My thanks as always to Patrick and the organising committee for inviting me to attend, and here are my disclosures. We've heard a great deal over the last few days about a wide range of different liver diseases. The final day has really focused on what I think for most of us is the commonest presentation of liver disease, which is of course fatty liver disease or alcohol. And for most of us, I'm afraid, these are the most challenging diseases to manage. And there is this terrible dichotomy between the public health issues of reducing alcohol consumption, reducing obesity, and the clinical issues of managing a patient who has reached an advanced stage of these disorders. We haven't, I'm afraid, seen the breakthroughs in drug development in these areas that we have seen in viral liver disease, and we're starting to see in liver cancer. But there are, I'm pleased to say, a few hints that good news may be on the horizon. So I'm very grateful to the presenters for sharing their slides with me. I've obviously been a little bit selective, so my apologies if my selection doesn't match your favourite selection. We start with fatty liver disease, an extraordinarily complex disorder with liver disease on a background of environmental and genetic factors. And Professor Pinzani gave his usual masterly review of where we are today and what our latest understanding is. And I think for me, the key message that came out was that we're starting to get to grips with some of the genetic factors that underplay the development of fatty liver disease. When I was a boy, of course, we had genes and diseases, and we started with the disease and we tried to find the gene. And nowadays we find the genes and then we try and look for the disease. And for fatty liver disease, we've had a plethora of different genetic markers, and we haven't really been able to integrate them until very recently. So what we now know about the development of fatty liver disease is that it is a metabolic disorder that in the right host environment leads on to initially fatty liver deposition, then on to liver scarring, and finally on to cirrhosis and sadly liver cancer. And as Massimo made very clear in his talk, this is one of the more challenging liver diseases because you can reach liver malignancy without going through advanced fibrosis. And I think many of us are starting to look at the public health implications of a potential huge burden of people requiring screening for liver cancer who don't have cirrhosis, but simply have some degree of fatty liver disease. And we will need to stratify our patients, and we will need to think very carefully about who needs scanning and who needs more aggressive follow-up. And this is where genetic markers are starting to play a role. And I think this was a very elegant study that Massimo presented, looking really at perhaps a conglomerate of different genetic markers to develop a polygenic risk score. And as Massimo showed, this polygenic risk score, featuring a whole raft of different genetic markers, can be used to start to predict who is at low risk and who is at high risk of developing liver disease. And you can see there's a very significant increase in risk of liver disease development if you have the high profile of all of these genetic markers. So I think this may be one of the early examples of genetic markers drifting into widespread application with screening for fatty liver disease. We'll obviously have to see how this plays out in clinical practice over the next few years. I'm also very pleased to see that at long last we've started to make a little understanding of the PNPLA3 mutation. This has kept popping up in gene screens for the last few years now. It always seems to be associated with poor outcomes, and we haven't really understood the mechanism of action. Massimo updated us on the current state of play, and it seems that if the PNPLA3 variant has a significant impact on the production of profibrogenic molecules from our old friend, the stellate cell. And whereas in the benign version of the gene, profibrotic molecules, cytokines, migration, proliferation are all relatively downgraded, all of these adverse events and this activation of the stellate cell is enhanced by the mutant form. So I think we're starting to understand the mechanism of this very important genetic variant, And that, I hope, will lead on to new drug discoveries. And given, of course, that PNPLA3 plays a role in a lot of liver diseases, there might be some common pathways here that we might be able to exploit in our therapeutics. Massimo finished by talking a little bit about the other genomes within us. We are, of course, a simple tube containing very large amounts of diverse genomes in our gut microflora, and it's been known for some time that gut microflora plays a significant role in the development of steatotic liver disease. We're just starting to see a little hint as to how this might operate. We're starting to understand the physiology a little more, but as Massimo made clear, this is very much an area of academic interest at the moment, rather than clinical practice. So moving from our broad overview of the factors underlying and the recent molecular discoveries, we moved on to our old friend diabetes, which is very long associated with fatty liver disease. And Professor Cusi gave us a masterly overview of this complex area with diabetes driving fatty liver disease. And he pointed out what we've known for some time now, which is the significant link between diabetes and fatty liver disease. It's clearly linked to insulin resistance and adipose tissue. And it's clearly important to screen the right number of people with diabetes. And we heard a lot of suggestions as to strategies to screen our diabetic populations using FIG4, elastography, or ELF testing. But clearly, with the very large numbers of diabetic patients in our communities, we once again will need to stratify if we're going to conserve our precious resources. And once again, the main focus from Professor Cusi was to illustrate the importance of managing the comorbidities, the link between primary care and hepatology. And that very much was a theme for me of day 3, which was how we're going to work together with the comorbidities and the interacting factors. And that was brought home, of course, by Dr. Buginese's masterly overview of all of the comorbidities associated with non-alcoholic fatty liver disease. It's rather stark to see them all highlighted in this way. I suspect many of us perhaps underestimate the importance of some of these, the osteoarthritis that disables people, reduces their exercise, precludes them from losing weight, and that, of course, exacerbates all of the problems that we've seen. And we should perhaps be a little more holistic in our view of our liver patients. They're not just livers on legs, they're human beings with lots and lots of comorbidities, all wrapped around this central metabolic derangement that's associated with fatty liver disease. I'm afraid fatty liver disease doesn't occur in isolation. We've heard a little bit earlier on in the day about diabetes and its association with fatty liver disease. But Dr. Cortes Pinto really highlighted the challenge of alcohol misuse in people with pre-existing fatty liver disease. And he drew our attention to what I think was a very elegant study showing this dose-dependent correlation between the amount of alcohol consumption and the probability of advanced fibrosis. And this, I think, is a really important message to us. It is very difficult for our patients with fatty liver disease to lose weight, but one of the things that we really can help them to do is to reduce their alcohol consumption. It's often easier to say reduce alcohol consumption than it is to do it, but certainly with support programs, with the drugs that we have available to help with alcohol cravings, with the support packages that we can put in place, I think we are in a position to start thinking about offering our patients with fatty liver disease some form of psychosocial and perhaps even medical support for their alcohol misuse. And I think for patients with fatty liver disease, we increasingly need to be much more investigative as to how much people drink. We need to be a little more progressive in challenging their assumptions and really trying very hard to get them to reduce their alcohol consumption. I think we all learn very well from clinical cases. Clinical cases are the bedrock of clinical practice. And I thought one of the nice innovations on day 3 was the introduction of clinical cases, some real world studies from experts in the field. And I'm grateful to Dr. Kelsey for their management of patients with fatty liver disease and comorbidities. And I think this really brought together all that we heard in the early part of the day, the importance of looking after the patient as a whole, the importance of thinking about screening for liver cancer, considerations for liver transplantation, taking a holistic view of obesity. Weight loss, of course, is the most important feature. We need to modify lifestyles. We need to think about treatment for obesity. And as you'll hear in a few moments, we're starting to see drugs for the treatment of obesity. Bariatric surgery, of course, has been one of the mainstays of management of excessive weight gain for the last 2 or 3 years. And we're starting to see how that will play an increasing role in our management of fatty liver disease. And the comorbidities we heard about earlier, hypertension, dyslipidemia, etc., we need to be vigilant, and we need to work with our primary care colleagues to manage our patients, not just managing the liver. I thought the consideration of treatment was an interesting reflection of how little progress we've managed to make. So moving on to treatment, the emerging field of fatty liver disease therapies is dominated at the moment by those treatments for obesity, and semaglutide is starting to move forward as a drug that may have significant potential in the management of patients with obesity and fatty liver disease. And we heard a very nice presentation from Michelle Long summarizing the clinical trial data, which is improvement in fibrosis without worsening of NASH. You can see that this is not yet a drug that will reverse our significant liver fibrosis, but it does help to improve NASH. And there are some very important ongoing studies looking at how these agents may perhaps protect us from progressive liver disease. These drugs, as we all know, are starting to become used as a class to help in the management of obesity. I don't think I yet quite understand whether the impact on the liver is independent of the impact on their weight, and those studies I'm sure will emerge in due course. And I think that this is probably one of the most progressive areas in the management of obesity-related disease that we've seen for some time. I think many of us are going to have to ask some difficult questions about whether this is a druggable disease. Is obesity a disease that we can cure by therapeutics, or do we need to be much more aggressive in taxation policies on fatty foods? Do we need to be much more progressive in our exercise provision for our patients? Is, I think, one of the questions that will dominate our thinking over the next few years. There certainly are going to be a cohort of patients for whom therapeutics are the only option, and simple modifications to diet or lifestyle is not going to provide the support that they need, and they will need some pharmacological interventions. But of course, the cost, the side effect profile, and the challenges of those are something that we're going to have to face. So I think we've had a brief glimpse over the fence into what our future will look like, and it's a future that will require quite a lot of detailed discussion with policymakers, with the pharmaceutical industry, and of course with our patients. And it will be interesting to see how many patients will seize the opportunity to take a weight-reducing drug rather than take an appetite for the local gym and increase their exercise. We moved on to discussions of alcohol, a long-standing bone of contention for hepatologists. We're all very, very familiar with the consequences of alcohol on the liver, and Dr. Pago outlined the horror story from COVID and admissions with alcohol-related liver disease, and this summary of the paper in Clinical Gastroenterology and Hepatology illustrates just how COVID has wreaked havoc with our patients and their alcohol consumption. And I think this is mirrored in all of our clinical practice. Alcohol, I'm afraid, has been seriously impacted by COVID, and the number of patients presenting with advanced disease is rising all the time. And I fear we haven't seen the top of this curve by any means at all. Alcoholic hepatitis continues to be a disease looking for better therapeutic options. For all of my career now, we've been playing around with steroids in alcoholic liver disease, refining the algorithms, but I think we'd all agree that the use of steroids is a long way suboptimal. But Professor Pago outlined the current state of play in terms of algorithms, excluding infection being a primary focus of the initial admission diagnosis, the importance of early introduction of antibiotics, and the importance of an early review of prednisolone. The benefits are potentially fairly small, and the potential for harm is quite considerable. So I think the importance of early assessment of response and early withdrawal if treatment is not showing benefit really does need to be emphasized once again. Liver transplantation has been widely used over many years for all forms of liver disease, but of course it's starting to move into the field of alcoholic hepatitis. And I thought that this was a very useful presentation looking at what happens to people who drink after they've received a new liver. And as you all know only too well, those people who do continue to drink considerably, those with early heavy consumption of alcohol, I'm afraid do rather poorly. And one has to start to question whether this is a good use of our very scarce organs if patients are going to return to the predisposition to alcohol consumption. And I think it makes the point very clearly how important it is to counsel patients, support patients, and assess them in the pre-transplant era. And that, of course, becomes very important when we're thinking about transplanting people with severe alcoholic hepatitis, because if those patients go on to drink heavily, then the organ, I'm afraid, will be of much less value because they will succumb to alcohol-related liver disease once again. And this, I think, was a very important study that was highlighted, showing that in the early liver transplant for acute alcoholic hepatitis, there was a significant increase in a relapse and return to alcohol consumption compared to standard liver transplantation for cirrhosis. Again, we're all wrestling with these difficult public health and ethical issues. Should we be allocating organs to often young people with very severe disease when a transplant may well be life-saving, but the effect of the transplant may be significantly reduced by the patient's inability to control their alcohol consumption over the medium and long term? And I think what we need is much more support for these individuals and a much more holistic approach. And that, of course, is very difficult when the patient's in hospital with very significant alcohol-related liver disease. And I thought this was quite a thought-provoking discussion as to how best to handle these very challenging ethical and clinical management issues. So we moved away at the end of the day from alcohol and fatty liver disease for a quick update on autoimmune liver disease. I want to focus on primary biliary cirrhosis and Professor Neven's review, showing what I think we have all believed for some time, that ursodeoxycholic acid was really very significant benefit. And what I thought was very fascinating was the discussion of FibroScan and its prediction of outcome. We use FibroScan as our first-line investigation, and it's perhaps salutary to think that we haven't really assessed it as adequately as we could perhaps have done in some of the conditions where we use it for. And I personally was very relieved to see that my practice of using FibroScan to stratify patients with primary biliary cholangitis has been validated now by clinical research. And clearly FibroScan is a useful tool right across the board in all forms of different liver disease. We've now had a number of years of second-line therapies for patients with primary biliary cholangitis. Obeticholic acid, of course, is the new kid on the block. Beta-fibrate's perhaps a little older, but for both of these agents, what we do see from the studies is that there is a significant improvement in the use of these agents in patients with non-responsive primary biliary cholangitis. So I think the long-term outcome of second-line therapy suggests that they are better than ursodeoxycholic acid alone, but sadly, they still don't completely abolish disease progression. And you can see from both of these charts that there still is some attrition from patients. So once again, ladies and gentlemen, another magnificent conference. I'd like to congratulate Patrick and his team for once again getting us all together, giving us a masterly overview of current liver disease, our current thinking. And I very much hope that next time, perhaps, we may be able to meet in person. But thank you once again, and thank you for listening.